Good evening, everyone, my beloved colleagues and students as well. Welcoming all of you to today's session. Very, very good wishes for all of you. And today, actually, the sequential ECG classes and is very common topic in our general practice. All family doctors, graduate, undergraduate doctors should know about this. So by rules, you all are actually muted. Whenever you need anything to ask, you just raise your hand and we will give you a chance. And we will not take too much long time. I think the class will be enjoying as before, and definitely the class always be interactive as before as well. So the silence is not actually expected amongst you, and from my side, I will be talking and I will be interacting with you. So with these few words, we like to go forward and have a look, please. The basics of the ECG definitely known, or a little or more. This is our introduction from our institute. And we will be talking today the conduction abnormality. So we divided the ECG classes into four. One is the ischemic heart disease. Another one, arrhythmias. And the next one was chamber enlargement, and today is the conduction abnormalities. Usually conduction problem means slowness of the conduction. That means conducting system of the heart. If before going to this topic, just look at the anatomy and the conducting system of the heart here. You just have a look. This is the SA node. This is internodal connections pathways. There are some names as well, and it is the AV node, and from the AV node bundle of His, and the bundle is a common bundle, and common bundle divided into two major branch. Is the left branch, another is the right branch. Interestingly, the left branch again divided into two other branches. These are called as fascicle, anterior fascicle, posterior fascicle, and the terminal multiple branching. In another word, it is called arborization. It's called the Purkinje fiber. So, by evaluating the conduction problem, by looking the ECG, we are able to identify where is the problem of the conduction, because the nature of the different parts of the conducting systems are different. Suppose the maximum heart rate produced by the SA node, another name, the pacemaker, natural pacemaker. If the conduction start from there, then the heart rate will be less. This is very usual. So when the conduction be generated in the down, if the upper part is in problem, that means if the node is blocked means failure to produce the electricity and the conduction of the electricity. This is the block. And then come to this AV node and the AV bundle. Very commonly, if we say block, heart block. So heart block means atrioventricular block, AV block. This is the commonest block for that. Heart block means atrioventricular block. From there, we divide the complete heart block, first degree heart block, second degree heart block. I will detail a little later. And then Purkinje fiber is here. So these are a specialized cardiac muscle. In addition, we must know that the general cardiac muscle in the atrium or in the ventricle, they have also capability to produce the electricity. So these are the exceptional features of the cardiac muscles. Our electrical axis is like that, though we discussed in a previous class, the straight line. If you follow my cursor movement, this is the electrical activity. So it is going down anyway. So these little information must be known to go to the final details. And we are going to directly to the block. As previous many classes, we have shown a normal ECG. So it is not normal ECG. Already we have decided what is wrong here. Please have a look that first degree heart block. So there is the P wave, this is the QRS complex and the T. If you go here and if you see here also. So the initial P wave, if we see here, is brightly visible. This is the P wave and this is T wave. This is the difference. And this is the PR interval. I think most of you know that the timing of the total time of the PR interval. So PR, if it is greater than 120 millisecond, we have to say that is more than 5 small square, then we say that PR is prolonged. But the very basic thing, how to calculate the PR interval from where to where? It is the beginning of the P wave and the beginning of the QRS complex. Why I am telling QRS complex? Because some ECG leads don't contain Q wave. So we can say this is PR, but some ECG complex contain Q waves, then it will be from the beginning up to the Q. So in some leads, we are calculating up to the Q, and some leads we are calculating up to the R. So rather to say from the beginning of the P wave up to the beginning of QRS complex. By definition, it could be a better one. So in this first degree heart block, the clinical consequence almost no. Just only problem in the conduction. There are many other reasons. We are not discussing the reasons, including the beta blocker as well. But thing is that if the reason is persisting, this block will be progressed and there will be the second degree heart block, complete heart block later on. This is the risk of first degree heart block. And look at that. The PR interval here is fixed. It is prolonged and fixed. And there is no variations. You see, fixed means no variations. Another observation, though I will tell later, look at here that this P is conducted by the QRS, then T, then again P conducted by the QRS. But if the P is not conducted by the QRS, including the T, then P is followed by the P. So this will be called as the drop bit or dropped ECG complex also we can say for understanding. In the first degree heart block, there is no drop bit. Strong differentiating point from others. Okay. Please again encouraging you to raise your hand if you want to know. Then the second degree AV block, they are divided into the Mobitz type 1 and the Mobitz type 2. The Mobitz type 1 is called one Quebec phenomena. One Quebec phenomena. So if you look at the PR interval here, this is the T, this is the P, this is the T, this is the P. I think I can make a mark here. This is T and this followed by P. So this is prolonged. This is prolonged and RR interval is same. But if we come to here, there is a P, there is also P, in between no QRS. So there is a drop bit. It's very characteristic. Drop bit is very characteristic for second degree atrioventricular block. Now thing is that if we consider many other leads, usually we discussed before the rhythm abnormality, that means the block, tachycardia or any abnormality in the rhythm, better to be identified in the long lead too. The name is long lead, so that we can follow multiple QRS complexes and the P wave. So if you see here, if you come down, very interesting, this is the PR, then T wave, this is the PR, this is the PR. So this is one, this one, second one, and the third one. Obviously, it is visible that this PR is being prolonged. So the difference from the first degree is that in the first degree block, the PR was fixed, though it was prolonged. So this is prolonged and not fixed. It means we can say prolonging PR and associated with a drop bit. So being prolonging up to which? Is it infinity? Somewhere in the later part, this P not conducted at all. That means the atrial electricity not conducted to the ventricle. So again, we are looking a P here. So this is the characteristic for one Quebec phenomena. Please, again, if you don't understand, don't feel shy to raise the hand. I am talking in my own pace. Right. So let me delete this annotation. Then I will jump to the next. So we discussed the one Quebec phenomena or Mobis type 1, second degree, the second degree AV block. And now come to the second degree AV block Mobis type 2. Usually it is uncommon, but it is actually worse than the previous type, no doubt, and occurs in myocardial infarction, especially the anterior myocardial infarction. That means the conducting system, that means the specialized heart muscle is also ischemic, so there is no conduction. And interesting thing is that here PR interval is fixed, like first degree heart block. PR interval is fixed, but there is drop bit. It's a very simple difference. In the first degree heart block, PR interval is fixed and prolonged, but no drop bit. But in the second degree Mobis type 2 heart block or AV block, PR is fixed, but added thing is drop bit. So you see that this is the drop bit P. Interestingly, P may not be in the same isoelectric line here. If the conduction problem is there, P may be inserted over the T, over the R, anywhere. If it is not dropped, so we can find no QRS in between. So there's a drop bit. So in summary, to make the simplification between the first degree and the second degree, the distinguishing feature is, strong distinguishing feature is presence of drop bit. I mean, if drop bit is there, it is second degree block. If there is no drop bit, but PR is prolonged, this is a first degree heart block. So it's very simple. And academically, it's very important, even in the undergraduate examination also. A general physician or a family physician, definitely. I have shown in previous classes, a family physician or the general physician, what are the ECGs to be understood. So we are trying our best, the commonest ECG visible in our practice and the exam as well. Now come to the third degree heart block. So third degree, another name is complete heart block. Whenever you need, you can make a snapshot. So don't feel shy, and you are permitted to take the snapshot here. If you look at this, you see this is this P wave. And interestingly, another P wave is here. You see at the beginning of the QRS complex. So sometime identification of the P wave become challenging. If you find that this is the P wave, up to P wave, okay, in between there is no QRS, and after this P wave, QRS is visible. Thing is that it is conducted or not. Though it is attached with the QRS, this is the liberty. The P can set anywhere in the tracing. For that, P selected now. Selected means automatically it is put at the beginning of the QRS. This P put in the root, and another P also somewhere else. Another P also somewhere else. Here you see, this is the P, this is P, here another P. Okay. If we look at the RR areas, so this is fixed. See, this distance is fixed, RR. And the PP area, this is also fixed. You see the distance from here, the red marks, this is also fixed. But thing is that there is no relation between the P wave and the QRS complex. No relation means if there is a relation, the distance could be fixed. Their distance could be fixed. That means all the drop beats are there. All the drop beats are there means actually there is no connection between the atrial activity and the ventricular activity. So RR maintaining the relation, PP maintaining the relation. PP maintaining the relation means the atrium maintaining their own contraction, electrical activity, ventricular is maintaining the their own electrical activity and the contraction. So this is the very common characteristics I told, but some tricks for my understanding to share with you. If I go back a little to show you the previous ECG, if we calculate this rate of the heart, how to calculate from RR interval, we discussed in the arrhythmia classes or the rhythm calculation classes. Usually this conduction delay will create the heart rate usually more than 40, suppose 45, 50. But if you come to the complete heart block, these RR interval around 40 or less than 40. Suppose how to calculate, most of you know that if we calculate this medium size box, that means a medium square, 1, 2, 3, 4, 5, 6, 7, and 8 around 8, a little more than 8. So if we divide 300 by 8, there will be the heart rate on an average. What will be the heart rate? Maybe around 40, less than 40, if you can calculate by yourself. So if any heart rate less than 40, our intelligence will guide us to check whether there is complete heart block or not. This is the tricks. So remember the heart rate in favor of complete heart block. This is very usual and very simple to remember. Then look at that. Where is the P? This is challenging. Where is the P? Because it could be the P, it should be in our mind, because it's wrongly placed here. If you are confused, okay, you just keep your suspicion here, then start counting or measure the distance from these up to another P. Then interestingly, you will find that this distance is equal to this distance. Then you will understand this is the real P. As we discussed, P can be inserted in any place of the tracing. So this is the complete heart block. Okay. For example, another ECG, you see complete heart block. You see many P's are here. 1, 2, 3 in between. So P to P distance is relatively not longer, whereas RR is far away. So again, 1, 2, 3, 4, 5, 6, 7, 8 around. So near about 40 or less than 40 heart rate. Okay, so atria and the ventricles are independent. There is no relationship. This is the inner message of complete heart block. Okay. Now, please interaction. Try to interact. Who will give the answer? Please raise your hand. I will give you mic quickly. What may be the block here? I am asking the question. I am asking only the block. Don't be busy otherwise. Yes, Dr. Karishma, please.
Sir, third degree heart block.
Complete
Complete heart block, yes.
Is visible that what is the heart rate?
It would be 35 around 40.
Around 40. So this is a very simple clue, doctor. Heart rate around 40, check complete heart block. Then you will be able to prove it. So, doctor, this is the P, right?
Yes.
This is the P. The next P where? Next P? Next. Can I give you the annotation? Can you show here if I give annotation to you?
Sir, I don't know how to use it.
Sorry. Who can take annotation?
P, another P is there.
Just to know, now many participants today. Anyone be interested to get the pen here to mark where is the P?
How to take the mark?
Then I can give the chance also to annotate. Anyone? Ankit, please. Annotate. This is the P, this is the P, here is the P, and then.
No, sir, I did it.
Oh, fantastic, you did it. Thank you. Don't give more marking here. Right, yes. In between, so this is the P. If it is the P, so this is not maintained, doctor. Is a longer, is a smaller. So in between there is another P.
Yes.
Which one it could be? Anyone? In between. This one And this,
This one.
yes. If I show this is the blue color,
Yes.
this is the P. In between another P, suppose this is the P, this is the P, another P in between. So you see the peaked part of the ECG, this is the P. So identification of the P is very important. P is very important. Thank you, doctor. Give me time to erase everything. Huh?
Thank you, sir.
Give me time. Everybody, be interactive, please. So it's very complete heart block. As a junior doctor, primary doctor is very important. Life-saving decision should come from the primary doctor, right? If you think that cardiologist will give the report, patient would die. This complete heart block is that much dangerous, right? Patient may go into syncope, cardiac syncope. Patient may not actually come round. Very important. Thank you, doctor. So this is the answer, and the heart rate around 35. So this is a third degree or complete heart block. Thanking you, Dr. Karishma. So just to summarize, the picture showing you first degree and the second degree Mobis type 2. It is very simple to remember, doctor, from the Mobis type 2 and first degree, because there is a drop bit. PR interval is fixed. There also PR interval fixed. But interesting thing is that in the Mobis type 2, PR interval may be normal, may be prolonged. So in the first degree, PR interval prolonged, usually not normal. In the Mobis type 2, sometimes found that PR is normal. That means PR interval is normal, but characteristic feature is drop bit. You see, this is the P and here is the P. There is no QRS complex. So it is counted in 2:1, 3:1, 4:1. You will read by yourself later. And here the one Quebec phenomena, Mobis type 1, and this is the complete heart block. So I think this picture is enough for your store. Thank you. Now come to the QRS complex. So our attention is for the conduction problem in the PR interval, very important area. Another is the width of the QRS, and the appearance of the QRS. Many things are there. For that, I didn't make a simplified as before I told in other classes the attention. So we have to attend a little more things here. So you look at this conduction in the right, but is a bundle branch block. So AV block means actually AV bundle block. I told you before. Now coming to down branch block, right bundle branch block, left bundle branch block. So we are showing first the right bundle branch block. If you understand the ECG orientation in the chest or in the limbs, left-sided ECGs, which are those? This is the, you see, right means you understand the right. V1 is the right. V5, V6, 4, this is in the left. 5, 6 especially. Right. So if you can remember that axis and others, you can easily understand. If we consider minimum the chest lead to make it very easy, from V1 up to V6. So V1 is the right representing lead. V6 is the left represented or representing lead. Conduction problem is there, means this is the increased width of the QRS. So if we look at in the V1, so QRS having increased wide, usually more than 3 small square. And again, you see that it is not only wide, the appearance is like M. You see in the V1 and V2 also, this is M. Usually, if in the right-sided lead showing M, the opposite-sided lead will show W. I talked in other classes, it is called the reciprocity. Those who attended the previous class, you can remember the reciprocity. If ST elevation is up in the anterior surface, in the posterior surface, the ST segment will be down, like the mirror. So the same thing happening here. If it is the interior part in the right side is M, then the QRS. In the opposite side, not always it is mandatory. You see in the one, it is a left-sided lead showing the W. Very characteristic for right bundle branch block. So similarly, what do we expect in the left bundle branch block? We expect that the 5 or 6, that means the left-sided lead will show M and the right-sided lead will show W. This is very typical, though in 100% cases, it is not the same thing happening. Okay. If it is so, the description we are telling this is the right bundle branch block, wider than 3 small squares. There is some secondary R wave in the V1, this RSR pattern to create MM, a shape of the M. So RSR pattern. Another name of this is called the fractionation. I will show you the fractionation in other slide. Right. And again, additional feature is the slurred S. Slurred S in the lateral leads. That means the 5 and 6. You look at, if I mark here, this S, I think obviously visible to you. This S is slurred. So it is going to be W actually, not happen so. So in the V1, it is wide, QRS is wide. So S also wide, rather to say. So it is another common term is the slurring. Slurring also important for the block. Okay. We are not hurried. Go slow. Okay. If you come here to see the left bundle branch block, same thing will happen. You see, in the V5, V6, this is M. In the V, we expect that it would be W, but not happen. Not happen. So the 1 is the left-sided lead. 5 is the left-sided lead. L means definitely left-sided lead. V6 is the left-sided lead. To make it simple, my junior colleagues, you minimum look at the chest leads from V1 up to V6. Then you will be able to identify. If you may forget this 1 and AVL. But we have to remember the lateral MI and other 1 AVL lead territory. We must remember. So left-sided wider. So this is left bundle branch block. Okay. Left bundle branch block. So the characteristics are here. Again, it is wider than 3 small squares. M-shaped QRS, RSR pattern or RR pattern. If, why we will say this is not S pattern, RSR pattern, because S by definition will be a negative deflection. If I go back, just to make it clear, maybe newer, relatively newer to someone, why we are telling this is S? Because it is below the baseline. So there is 2R in between 1S because it is below the baseline. But if the coming slide, there is R and R, but in between there is no S because it is not below the baseline. So rather to say this is RR pattern, RR pattern. So another R is denoted by the prime, prime. We said that this is a dash like, rather to say the prime, RR prime, RS R prime like that. So this is a left bundle branch block, easy. Again, look at, you see this small lead and enlarged here. So there is a wide QRS, it is more than 3 small square. This is AVR, look at. So R means right-sided lead, right? Right-sided lead. So usually right-sided lead, AVR is not positive. There is a reverse. It always will be down. So better not to make the things are complicated. Look at the chest lead, lead 1 and lead 5 or 6. What you are looking here, the QRS is a large picture is there, more than 3 in the V5, V6. You see that there is a W in the V5. So down, right, is a W, not M. So we expect that there will be M in the V1. So if it is the V1, where is the V1? This is a V1. But it could be wide, may not be M also. So remember, this notching or fractionation not always be present, but fractionation is very characteristic feature for the block. That means the branch block. So fractionation in the lateral precordial lead. Precordial means chest lead. 5, 6, this is a lateral. So if it is enlarged here, you see that there is a fractionation. W means fractionation. Here is a fractionation. You see lower part, wide area. So what could be the diagnosis? This is the left bundle branch block, and the fractionation indicates this is really true LBBB, left bundle branch block, true. Okay. And if fractionation is not there, we would be confused. It may not be left bundle branch block. Now come to this ECG for you. Who can identify? Please look at. Don't be busy with any other thing. Be busy with the block only. Which block is here? Right bundle, left bundle, or other? Think yourself and give your answer. Raise your hand, please. Someone lowered down hand. Why? Are you confused? I think Ankit is trying. Ankit lowered down hand again. Ashish, please. Ashish, can you unmute, please?
Assalamu alaikum, sir.
Welcome.
Sir, B6 sir, I am so left bundle branch block.
You are thinking left bundle. So this is a wide QRS in the V5, V6, you mean? And what happened to the
Left
V1?
bundle branch block.
V1 also wide, right? If we are confused, so the group. Ashish, can you unmute again?
Yes, sir.
If we are confused by the V1, so we can come to the V2. If you're confused by the V6, so come to the V5. So there are nearer leads. So if you start from the V1, what you are looking, is there any fractionation in the V1 or V2?
B2, sir.
Yes. Ankit also can talk now. So this is a fractionation.
Sir, right bundle branch block.
You are giving the answer. Just be with me. Is M pattern or
Yes, sir.
W pattern?
Sir, M pattern, sir.
M pattern. Is it RSR or RR?
Yes, sir.
Which one?
Sir, RSR.
Where is the S? Ashish, anyone? Aditya, is there any S here? Who can say? Is there any S?
No, sir. B2 te sudu R. B3 te yes.
There is no S. I told you S should be the below the
Yes, sir.
baseline. Below
Negative
the baseline.
depression.
Below the baseline. So, Ankit, clear? This is only RR.
Yes,
Double
sir.
R. Because due to fractionation. Fractionation, right? Fractionation. Eh? Good. So, this is a wide QRS. In the opposite lead, that means the lateral 5, 6. So, it is becoming wider. Appears to be W, but not clean cut W. But what else here visible? In the 5, 6 lead, Dr. Karishma?
Sir, this florid, this down S, which we call deep S, also is there.
Deep, rather, we said the slurring of the S. Slurring
Yes,
of the S.
it's
Very
yes.
characteristic for which block?
right.
Right bundle branch
Branch.
block. Right bundle branch block. Thank you. RBBB. Now, to ask you, though I am not showing this thing, right bundle branch block divided into the incomplete block and the complete block. Dr. Karishma, can you say, is it complete or incomplete block in this ECG?
It's complete, sir.
Why complete? Because it is more than 3 small square wide.
Okay. Yes.
But if it is less than 3, Less
It's
than three,
incomplete.
less than 3 also not normal. What is the usual?
Yes, sir.
The
Actually,
choir is wide. It is not 3. It is less than 3. Right.
it's less than 3. Yes, 150 it come.
So, but it is
Around one.
just less than 3. So it will be incomplete right bundle branch block. And this incomplete right bundle branch block is that much important that usually we find in the normal heart incomplete RBBB. So it's a very normal variant, So we must be aware of that. We must be aware of that. Next ECG. Please look at and get ready to give the answer. Ankit is ready. New participant to give the answer. So we are asking only the block, and don't be busy with other diagnosis. What type of block, if any block is here? Sorry, 2019. I'm sorry, I cannot utter your name. Don't mind. Huawei. Please be unmuted and give your answer. Your mic is given.
Hello, yes, this is Dr. Abdullah.
Oh, Abdullah, sorry.
Yes,
Your
no, it's
name
okay.
is actually anyway.
Yes, sorry,
What is your
it's okay.
your answer? What is your answer?
Yes, actually, this is there is M shape and lead one
M
and
shape.
lead M shape.
Lead
Yes.
one. Is M shape in the lead one? I'm not asking lead one, doctor. Just be busy with the chest lead. There is additional features. V1 and V5 or V6. You can compare here.
Yes, actually, the S deep, we have the deep S.
The deep S is here, but to identify the typical features of the wide QRS,
we have
wide QRS,
M, yes, M shape, V5 and 6.
Yes. That means it is in the left-sided lead. Left-sided lead.
Yes, left bundle branch block.
Left bundle branch block. I think everybody will agree. If you don't agree, raise your hand. If you want to say, you can say. Otherwise, lower down your hand. Dr. Karishma having query maybe, please.
Sir, it's very difficult in general practice, in daily practice in ER, also to differentiate between left bundle branch block and acute MI, especially universal MI. Any clue?
Very difficult. It is said that if any left bundle branch block is there, so the other informations of the ECG very difficult to be explained. Okay. So first thing, identify left bundle branch block. Then what you will do as a general physician? What we do usually, we talk to the patient, any symptom or other. Sometimes we do the ECG only for routine checkup, right? For routine checkup, patient does not have any disease. And maybe rarely, in my experience also, maybe if you have seen a lot of patient does not have any problem, but wide QRS is there. Seems to be left bundle branch block. I got this experience also with some patients. So in this situation, we are not worried. But if patient having chest pain or patient having predisposition for the heart disease, and we are getting the left bundle branch block appearance in the ECG, better to refer the case to the specialist. Okay, Dr. Karishma?
Yes, sir.
So this is the technical message that LBBB is there. So ECG is distorted to explain other thing additional. Though very, very expert people can tell, right? But in our level, even the general physician also, they will face trouble. So first identify left bundle branch block. That's enough. Okay. So in practical situation, if patient having the chest pain, ECG showing left bundle branch block, it is said that this is the MI until proved otherwise. It may be a clue also. Chest pain with LBBB, think that this is myocardial infarction. So what does mean again? Refer the case to the CCU. Cardiology, right? Remember.
Yes.
So this is the LBBB. Now in this ECG, again, you are allowed to raise your hand. First, what do you like to say here? I'm sorry, I cannot enlarge it because the resolution is not good here. Ready, Dr. Abdullah, ready?
Yes.
Can you explain, Dr. Abdullah? Want to see
Hello?
the new hand to raise? Yeah, Dr. Abdullah. What is your opinion?
Actually, there is deep S and V1,
Okay,
deep S V1 and V2.
okay. So we need to see the opposite V5, V6.
Yes,
So what?
V5 and V6. There is
Yes. Is there any fractionation of the
shape,
QRS?
M shape.
QRST there is a fractionation. It is not M. M
Yeah.
may be here. M may be here,
Mm.
seems to be, right?
Mm.
But this is down. There may be M or seems to be W also.
Yes.
In a simplified manner, we can
Yes.
say that fractionation is there. Fractionation. Fraction, right? Broken,
Yes.
notching.
Fraction. Yes.
Yes. So now, what could be the diagnosis here? An intelligent extended information you can get from the limb lead 1, 2, 3. There also you see broad QRS, right? 1 also here.
Yes.
So which block it is?
Yes.
Which block?
This left.
Left. You are meaning left bundle branch block. Any different
Left.
opinion? Anyone want to
Yes.
say? Anyone? No one. So you are with the same opinion because the left-sided lead is having wide QRS and the fractionation. Again, it is supported by the limb lead 1 for the limb lead 1 also representing the left side of the heart. So this is left bundle branch block. I believe that you understood more or less what is the block and how to identify. In this slide, I like to show you that whenever QR is wide, you see QRSW, that means widening, you have to think. Then look at V1, V6 in addition, look at the limb lead 1 in addition. So very simple to remember, limb lead 1, chest lead V1 and V6 and compare. Then you will be able to identify this very typical RBBB, typical LBBB, but somewhere you find the widening little, but no fractionation. Okay. So it maybe in another terminology we can use, it is called intraventricular conduction defect or disorder. That means there are some other problem inside the heart which cannot be labeled as typical right bundle branch block or the left bundle branch block. So it is not uncommon. I think Dr. Abdullah, Dr. Karishma and others, those who are seeing the patient more, you have this experience. You cannot label this is RBBB or LBBB. So it is called intraventricular conduction disorder, or rather to say the defect. Yes, it is called IVCD. Right. So we are going to show you very typical 12 lead ECG with an long lead 2 rhythm strip. What you are looking here? Please give your answer. Is there any block? Raise your hand. So block means where to look? Lead 1, V1, V6. So which block is here? Or intraventricular conduction defect? Oh, we added another information. Ankit is ready. Ankit.
Sir, one block আছে sir. AV block.
Lead one, AV block is the PR interval, right? So we are considering the bundle branch block also. Is a PR. PR
6
is
and
near
5,
normal. 5, 6 it is
B6 and B5.
B6 and V wide QRS. Is there any fractionation?
Yes, sir.
Is there any fractionation?
No, sir.
Anybody can see with clear
Okay.
eyes and any fractionation here? You understand the fractionation? Notching. Is there any notching? You see?
Zoom করলে একটু বোঝা যাচ্ছে, sir.
So this is the notching. The typical notching is here. You see? Notch. You understand the notch? Right?
Yes, sir.
Notching is there. So notching means very typical for block. So Ankit saying what?
Sir,
Left
bundle
bundle branch or right bundle branch block? Dr. Karishma also, please. Dr. Karishma.
Left.
Any query in your mind?
Sir, the rhythm is also not regular. See this ECG.
I'm not asking the rhythm, doctor. We are discussing on the block. Try to identify the block. Maybe regular, may not be regular or irregular. Not the matter. Maybe. You see, if you long lead to, it is not regular. This is true. But asking the block, which block? Right block or left block? Not clear. So someone answered, this is the left block. Let us see. Intraventricular conduction delay or LBBB, which you want to say, RBBB or LBBB? If we said that there is a fractionation, actually I need to edit it also. Sorry. Is the screen visible? Ankit, can you say screen visible?
No, sir.
Sorry for this technical issue. Intraventricular conduction delay. So could it be intraventricular conduction delay or LBBB? What we like to say? LBBB or RBBB?
Sir,
If we are in the
LBBB.
same opinion of the fractionation here, right? It could be LBBB again. But the width of the QRS is less than 3. Though there is a fractionation, but width is not in the diagnostic value. What could we have to say? Intraventricular conduction delay. Right? Understand my point?
Yes, sir.
So we have to be very cautious to calculate this wide. Is it more than 3 or not? Most of the leads, author telling that it is maybe not more than 3 anywhere. And if they consider the fractionation, I told in another class, always we have to see the same feature in the 2 leads. Even in the MI also, ST elevation should be in the corresponding 2 leads. So if we tell that the fractionation is here, but it is not in any other lead, so we can ignore also. In that case, the opinion of this ECG could be IVCD or LBBB. Confusing. In that case, what GP will do now? Dr. Karishma, you are the GP. What you will do? Karishma, if you are confused, this is IVCD or LBBB, what you will do?
I will call the cardiologist, and actually we should see the sign symptom of the patient also.
First is a symptom and sign, but even then, symptom sign we don't know, but we are confused. The block is not there, so minimum we have to talk to the cardiologist. They can give good answer. So usually ECG be evaluated by the cardiologist. It is the fact. But as a GP, some emergency ECG we must know about. Okay. Now come to this ECG. Can anyone try now? Dr. Abdullah. So 2 important features, width and the notching. Try to identify wide and notching is favorable for the block or not.
No, sir, it is there. In 2,
Please first look at the
in 3,
V1, V6.
in,
Doctor,
in 2,
better to look at the V1, V6.
yes,
In addition, lead 1 is a very standard to see the block, branch block, whether it is.
V1, yes,
So the V1, the V5, V6, V5, V6, slurred S, right?
V2,
Slurred S. And the V1, this is wide. Any fractionation?
yes,
But is the wide is more than 3 or not? This is also important question. There is a fractionation. You see the broken here, a little fractionation. But fractionation more visible in the V2, but not visible in the V3. We are confused to say there is fractionation or
V3.
not in the V1. So not very much confident to say about the fractionation. This is the rule of 2. Ankit also telling. Ankit, can you unmute? Can you unmute now?
Yes, sir.
Okay.
Yes,
What are you
sir.
thinking? What are you thinking? Is it block or not?
Sir, I think V2 sir, it's delta wave, I think so.
You are thinking
Sir,
delta
this
wave
is
is the
also
initial
intraventricular
sorry, Dr. Karishma.
delay conduction.
What is the
This is
reason?
not block, sir.
What is the reason?
Because it's only in one lead.
Only one lead
The-
fractionation.
we
And the
do-
wide also, are we confident that this is more than 3 or not?
Wideness is this. Yes,
Wide also
Yes.
possibly 3
it's
or
not more than 3.
Oh,
so we are busy with the bundle branch
Okay.
block here. So you are right. There is a bundle branch block, no doubt. Okay, maybe intraventricular conduction delay is there.
Delay.
But why we are telling the trifascicular block? The major fascicle, that means the major branch the conducting system is. Try to remember my understanding, please. One is a common bundle. It is called the bundle of His. Another is right bundle in the right side, left bundle in the left side. And the left bundle divided into 2, anterior fascicle, posterior fascicle. In any ECG having the block source from 3 major bundle, that means the common bundle, right bundle, and the left bundle. Left bundle may be complete LBBB or fascicular area also. Suppose anterior fascicle, posterior fascicle. So there are source of 3. Then we tell it trifascicular block. It is almost equal to a complete heart block. Okay, Dr. Karishma, can you hear? So now let us see.
Yes, yes.
If we see the long lead 2, is there any prolonged PR? Ankit was talented before to identify something else. PR about what is the PR? Ankit, Dr. Abdullah, is the PR is normal?
Prolong, sir.
Prolonged.
PR,
Prolong. So prolong means a component we found
prolong,
from
yes.
a component we found from the
WPW
AB bundle. AB bundle. That means a common bundle, bundle of His. And then, is there any features of the right bundle branch block? What do you see? V1, wide V1.
V1.
It could be, right? There's a slurred as also, Dr. Karishma. We cannot ignore that it is right bundle or not. Slurred as also another component. So there is a right bundle branch block. So common bundle branch block, right bundle branch block. Now, what other
Branch
component? Other component means from the left bundle. It is called anterior fascicle, posterior fascicle. How to identify? By saying or by telling about the axis deviation. I think you attended before, some of you in our classes, right axis, left axis. Is there any problem of the axis? Those who attended, try your best. Suppose if it is the 1 and the AVF, if you consider AVF, So AVF mostly down here, right? It is up. They are also, sorry, there's some noise, sorry. So there is also lead 2 mostly down. So F is down, 2 is down, and the 1 is up. So which axis deviation is here? Is the left axis deviation or right axis deviation? The AVF, if you see the ECG by your hand, in the left thumb over the lead 1, right thumb over the right, that means AVF. So AVF positivity more means right side activity is more. One action is more means left side activity is more. So how can we summarize here? That it is positive in the left side, negative in the right side. So left side activities is more. So where will be the axis? To the left or right? Sabina. Suppose the electrical activity more in the left side, then we term this is left axis deviation. Axis means electrical axis. So electrical axis moving towards the left. It is the left axis deviation. So where is the left axis deviation? It is called anterior hemiblock. That means from the left bundle. So in summary, we get common bundle block, right bundle block, and one component of the left bundle block. So there are 3 blocks. So summary diagnosis is trifascicular block. Clear, Dr. Sabina? Okay.
Yes, sir.
Thank you. So lower down your hand. I think we could finish within few minutes. Don't worry. So the question is another type of ECG. Who can say? Can you try? What is this? It's very simple to take the history enough. But if you don't see the patient, you are given this type of ECG, we must be able to identify the normal appearance of ECG also. Is there an abnormality? First thing, yes, it is not the normal ECG looking like, but for the person, for the patient, is it dangerous or not? Another question. There are some additional marking, you see. Electrical activities are created here in these points. Started from here, electrical activity. Usually electrical activity start before the P wave. That means one QRS complex, usually before the Q wave. This is lead 1, lead 2, lead 3. You understand that according to the leads, electrical activities are recorded. So whenever electrical activity recording start, it start before the P wave. Can anyone see that this electrical activity started not before the P wave? Can anybody say? If you look at here, this marking, this is the QRS complex. When lead is changed, you see 3 and ABF, transition of the electrical activity generation in another lead, this started just before the QRS complex. QRS representing the ventricle. It is called the the pacing stroke. Pacemaker stroke means the lead is being changed, there is a marking. In everywhere you get the marking also, but abnormality of the marking is here. They start from the beginning of the QRS, not before the P. Clear now, Dr. Abdullah and Dr. Karim?
Yes, sir. This pacing, right? Pacing.
Pacemaker ECG.
Pacemaker.
Pacemaker ECG, and this is single pacing. Why single pacing? It is only in the ventricle for that, before the ventricle. What is this? There are some pacing marks also. You see, double marks at the beginning of the QRS and at the beginning of the P. Beginning of the P means in the atrium and at the ventricle. There are 2 pacing. What is this? Nowadays, people having the pacemaker, so we should never forget it. We are following a patient in the chamber or in the hospital in the bed, patient having the pacemaker. If ECG is shown to us, we will be puzzled if we don't know. Though ECG is normal as patient having the pacemaker, patient is okay in the heart, but we are confused. This is maybe abnormal, this is maybe abnormal. So at the later part of my discussion today, I have shown you the pacemaker ECG. Usually dual pacemaker is nowadays used more, right? Double chamber, dual means double chamber pacing. So dual pacemaker, double chamber pacemaker. Finally, thanking you all, and we like to thank all of you from our heart that you joined the program in the last maybe 3 classes we finished. The arrhythmia is available in our YouTube. So those who couldn't join, or today those who are there, you are not oriented the YouTube link I'm giving for all of you. You can click there and see later. You can make it copy also, or subscribe there. Not only ECG, many other issues are visible in the YouTube. I hope you may have some question. If you want, you can raise your hand. No. If it is no, we are happy and thanking again. Hope that in future we will be with you with other very simple things, especially the undergraduate and the postgraduate, both doctors and students also can be can get the benefit and the privilege to learn in the free session, as well as hope that you will be in touch with us in future. So with these thanking words, thank you very much. See you. Bye bye.
Thank you. Thank you.
Thank you.